Yeah, you would think that the stronger the estrogen or the higher the estrogen dose is, the more SHBG is increased. It does seem like also on paper that if you put in, perhaps find, you're already taking a synthetic estrogen and a synthetic progestogen. What if you put in a synthetic androgen? That would probably decrease your risk of breast cancer.
Yeah, it's an interesting sort of postulation and thought experiment. I know you and I were on a podcast probably close to a year ago at this point, and we're talking about contraceptives and the free androgen index and all these effects, and kind of wondering aloud as to why there wasn't some sort of a synthetic androgen that was added into a contraceptive at some point. And I think it's partially because of the sort of reputation or stigma that surrounds androgens. It's like, well, that's a male hormone. Why would you give that to females? Which we've both spoken about many times, that there's actually, for most women, a higher circulating level of testosterone than there is estradiol.
Yep.
But I think we landed on something like 0.5 milligram to 1 milligram of oxandrolone as being a pretty solid choice. Because when you look at some of the studies with women in Turner syndrome, it doesn't appear to have a profound increase in insulin resistance. It seems to be neutral. Now, if you put these women on a euglycemic insulin clamp, maybe you do see that oxandrolone actually does cause a bit of insulin resistance, but maybe not. But certainly bioidentical testosterone seems to in a dose-dependent fashion, as well as some other androgens. So I think that's what we landed on. And sort of speaking to the tug of war, there's an opposing effect in the liver of androgens and estrogens on sex hormone binding globulin. And there's some pretty interesting numbers there when you look at how much something is able to raise that sex hormone binding globulin.
Yeah, you would think that the stronger the estrogen or the higher the estrogen dose is, the more SHBG is increased, because when it binds that estradiol alpha, that directly increases synthesis and release of SHBG. But progestins can have a profound effect on this as well. For example, drospirenone without any estrogen raises SHBG precipitously. So finding the nuance of that, not only in the liver, but in the breast tissue, is important. We love going through clinical literature, and regardless of it could be a synthetic estrogen, synthetic progestin. We love SERMs, selective estrogen receptor modifiers, SARMs, selective androgen receptor modifiers. We kind of lament the fact that we've missed many decades of research, both males and females, on androgens potentially included as part of hormone replacement therapy or potentially as part of contraceptives, largely just because there was a whole bunch of research and there was none. So I think that's really a public health problem that needs to be talked about and addressed more as time goes on.
Yeah, it's really, like I said, just this sort of reputation that testosterone and androgens have, where people don't want to touch it, a lot of times don't want to talk about it, and as a result, there's kind of a lack of knowledge in that area. So there's not a lot of attention that gets paid to it. So looking at the different forms, the different routes that estradiol can be administered. And I think we had a brief podcast on contraceptives in the past, oral contraceptives specifically. Yep. And I had thought at the time and kind of wondered aloud that, maybe if someone's taking oral estrogen, like ethinyl estradiol in their contraceptive, if they switch over to transdermal, like a patch, that they're not going to have that same increase in sex hormone binding globulin. And doing our literature review, our non-systematic review, if you will, for this podcast, I found out that's not the case, that there's actually similar increases in SHBG, similar decreases in insulin sensitivity whenever contraceptions with ethinyl estradiol are used. So for example, contraceptive using oral ethinyl estradiol, sex hormone binding globulin goes up by a little over 200 points. Pretty significant. About the same for transdermal, like a patch-based contraception, goes up from 63 to 264 approximately. So about another 200-point increase. Slightly smaller increase when you're looking at the NuvaRing vaginal contraceptive preparation. Goes up from 61 to about 220. But still a really substantial increase. So there's something about that duration of effect of the hormone and always having that circulating, not just the first pass effect that is driving the sex hormone binding globulin and driving some insulin resistance. And we kind of speculated about the differences in lean body mass composition. So there seems to be a neutral or negative effect with oral contraceptives. I've heard some people postulate that maybe if you're taking a ton of estradiol, that it might be a little bit anabolic, but I haven't seen the data to support that. But maybe if you're looking at a transdermal delivery system, then that's going to be slightly better, because you can think of it as kind of like a testosterone pill versus a steady state of testosterone.
Yep.
And that steady state, and we know that women's estradiol is part of what drives their response to exercise, which is about proportional with men, according to their body size, based on some of the information that Dr. Andy Galpin has put out.